Okay, so today we'll continue our look at the Singapore health system. So we're looking at the 3 M's: MediSave, MediShield and MediFund. So we finished up last Thursday looking at MediSave, medical savings accounts. We've looked at the contributions that people have to make. So as we said, in Ireland it's equivalent to something like PRSI, but instead of the money being put into an aggregate pool and then paid out on individual needs, it's put into individual accounts. Whatever money the individual pays into the system follows the individual. So the first M is MediSave. So it does take a certain proportion of income, just in the way the PRSI does in Ireland. So we looked at the different balances and the growth, and we finished up with the advantages. And the key advantage of medical savings accounts is on incentives. That it encourages individuals to weigh up benefits, but also costs. That if they're going to pay for additional healthcare, they must look at the cost. So last week we listened to a short clip where there was issues about the availability of a medicine under the medical card in Ireland. And for the individuals, any medicine that is in any way better will always be demanded. But what a system must take into consideration is the costs. Is it 5% better, but costs 1,000% more? So what is the difference between them? What are the gains? And there are other advantages of medical savings accounts. They also offer some disadvantages. There's little or no risk pooling. When everybody's money is combined into a common or aggregate pot, if somebody has a fairly large claim to make, well, there's a large amount of money available there to which to meet that claim. But if it's based on individual contributions, well, the pot isn't going to get sufficiently large. So persons with catastrophic illness, if they have to cover it from the medical savings account, will exhaust their account pretty quickly. That if you have fairly high cost health service needs, and you have 15, 20, 25,000 in a medical savings account, that could be used up and exhausted quite quickly. So what then does that individual do? So with the catastrophic claims, there is then the need for catastrophic insurance. But like with all insurance policies, it will be patchy. The insurance policy won't cover everything. The insurance policy will cover what's in the contract. So healthcare needs might arise that might not necessarily be covered by the catastrophic illness. So there can be a lack of risk pooling, and then with the catastrophic insurance, there can be patchy coverage. Because the money or the inflows into the account are based on income, low-income people will have a very small amount in their account. Are they going to get the opportunity to actually build up the funds? So you might say that to put in 5%. Big difference between somebody earning €300 a week and somebody earning €2,000 a week. The 5% contribution would vary by a huge amount. And then there's the potential for high administration costs in collection, record keeping and disbursement, if each person has to have an individual account. So at present, we deal with individuals on the claim side. If you have to make a claim through social welfare, you're dealt with individually. But the money is collected aggregately. So the funds are accumulated and put together. If it was a case of having individual elements on both sides, the cost would be huge. So would we have a sufficiently effective, sufficiently efficient system of public administration in Ireland to handle that? That if they have difficulty in handling one social insurance fund, how would they handle 3.5 million individual savings accounts? And how would they be able to step up to that? So the medical savings account does offer some advantages and does have disadvantages. It isn't a silver bullet which will cure all the ailments. And as we saw in the earlier slide on the amount of money in the Singapore health system that flows through the medical savings accounts, it's only about 7 or 8%. The second M is MediShield. And this is the insurance paid through the MediSave funds. Again, it features incentives. It's not so much insurance, and if you have a particular claim, the insurance company covers everything. Built into the insurance scheme under MediShield are deductibles, co-insurance, and then claim limits. So deductibles where the individual must cover the first amount. So if a claim is, say, for €5,000, there could be €500 deducted. that what you'll actually get back is 4,500. There can be co-insurance where 100% of the claim won't be covered. It might be 90%. So for each extra euro you need spent, you get 90 cents from the insurance, and you have to contribute 10 cents yourself. Again, trying to weigh up costs and benefits. So you're not imposing the whole cost on the individual, but a limit of that cost. And then there are limits on how much can be claimed. So a number of years, this is 2006 data, 60% of the Singapore population were covered by MediShield, covered by the catastrophic insurance. 78% were in what we consider the cheapest plan, and 22% in the two higher plans. But they generally have to deal with hotel accommodation, hospital. What type of room do you want? So 78% were going for the lowest plan. So how does MediShield work? Well, first of all, there's the deductible. So the patient pays the first 1,500 or 1,000 euro from their MediSave funds. So again, with the exchange rate, that's about 750 to 500 euro. So before you can draw on the catastrophic insurance from MediShield, you must cover a certain amount of it yourself. So the deductible is subtracted before any insurance is paid. And then as the amount increases, the yellow box here is the insurance that will pay for it. And that will actually cover now up to 80% of the entire claim. But even as the cost increases, as you move up along this direction here, there's this co-insurance that again is paid from the MediSave account. So it could be a small amount, so 10%. So each time extra money is spent, 90% is covered by the insurance and 10% by the individual. Again, trying to encourage the individual to be cost conscious, and this not at a huge level. You're told go into the car showroom, you can have any car you want, but you must cover 10% of the cost. Would you take the cheapest car? Would you take the most expensive car? If you had nothing to pay, you'd definitely take the most expensive car. If you had everything to pay, you'd go for the car that best suits you. In this instance, the costs are sufficiently large that a lot of the costs will be covered by somebody else. So 90% are covered by the insurance, and then 10% is covered by co-insurance. And then there are limits. Once you go above a particular limit, the insurance will not pay out. But the insurance limits are extraordinarily large, so they rarely kick in. So MediShield will pay most of the claim, and the patient pays a small co-insurance amount. So again, it's working on the basis of incentives to encourage the individual to weigh up and balance costs and benefits. And the final element of the 3M jigsaw was put in place in 1993, and this is MediFund, and this is sort of their social welfare backstop. What if people don't have money in a medical savings account? What if they don't have the income to cover their healthcare needs? Where can they turn? Do they simply go it out? As we said at the start, health is a different product than most other products. If you can't buy a car, what about it? Get the bus. If you can't get a particular operation or procedure, you may die. So they are somewhat different. So MediFund was set up in 1993. MediFund is an endowment fund. And that simply means that what can be spent is the earnings. So it's not an ongoing or a current expenditure. An endowment fund has a certain amount of money in it, and that money is invested and generates a return. It is that return that can be spent. So the initial lump sum is always there. So it's a stable source of revenue. Depending on where the money is invested, the return can vary, but the amount of money will be largely the same. So the endowment fund was set up, and it was set up with a fund size of 1.6 billion, or reached a fund size of 1.6 billion in 2008. They do put more money into it on an ongoing basis. And it does increase savings, it increases investment, and it sort of brings about revenue that can be used elsewhere. So the interest income is used, so this is the earnings, to help needy Singaporeans pay for their medical expenses. So they have this fund that's available, it generates a return. If it was generating a return of, say 5%, you'd be looking here at about 80 million available. If the return was 5%, the return was a bit higher, you want the money available would be quite higher. So it's a safety net for Singaporeans who cannot afford medical expenses, even after government subsidies, MediSave or MediShield. So it ensures no Singaporean is denied access to basic medical care because of an inability to pay. So there is somewhere else you can turn to. If you don't have the funds yourself, don't have the medical savings account built up, don't have the insurance. And even after the government makes it cheaper, if you still can't pay for it, there is somewhere else to turn. So the Medifund may appear to be quite a small amount, but because of the size of the claims, it does stretch quite far. So the number of approved applications for the last year here, 2006, was 300,000. Remember, the population of Singapore is quite similar to that of Ireland. So 300,000 approved applications in the year 2006. And they paid out 40 million. So in 2006, hard to know what the size of the fund was, but that would be generally the total interest income. So an endowment fund is a useful way of funding a government scheme because it provides a stable level of funding. In Ireland, we've seen some of the difficulties of having unstable revenue. Tax revenue in Ireland in 2007 was 47 billion. Okay, we'll spend it. Tax revenue in Ireland in 2010 was 31 billion. We were 16 billion short, but the expenditure was at the same level. Whereas if we wouldn't have endowment funds for everything, but had created endowment funds for some forms of government expenditure, the money would still be there. It would still be earning interest in any given year, and this is the basis on which the Medifund is set up. So you can see the number of processed claims increasing up to 300,000, and the annual amount of payouts. And while 40 million Singapore dollars, 20 million euro, mightn't seem like a huge amount, you must remember that the health in Singapore is heavily subsidised to begin with. So if you do have a stay in hospital, it's not going to be costing you 2, 3, 4,000 Singapore dollars. The cost will be in the hundreds. So you mightn't have a huge cost to cover because it's heavily subsidised in the first place. So 40 million would go a long way and is covering about 300,000 claims. So they are the 3 M's: Medisave, Medishield and Medifund. So how does the health system work? How does it all come together? Well, just like in Ireland, there's a public-private mix. A certain amount of healthcare is provided by the public system. The government owns and runs particular healthcare facilities, and a certain amount of the healthcare is provided by the private sector, privately owned healthcare facilities. So for both primary and secondary care, the public-private mix in Singapore is 80-20. Actually, in the primary care, it's 80% private, 20% public. So just like in Ireland with GPs, the vast majority of primary care comes from the private sector. GPs being individual entrepreneurs in a sense. And in secondary care, it's 80-20 in favour of public. So just like in Ireland, secondary care in hospitals is dominated by the public sector. There are private hospitals, but they only make up a small portion of the overall level of provision. So in Singapore, there's 8 public hospitals and 5 specialty centres that account for 80% of inpatient beds. So general hospitals like CUH and specialty centres dealing in particular areas have 80% of inpatient beds. 13 private hospitals account for the remaining 20%. So clearly there's a size difference between the public hospitals and the private hospitals. 13 public hospitals have 80% of the beds. 13 private hospitals have 20%. So the numbers are the same, but the number of beds is different. And 80% of primary healthcare is provided by private GPs, just like in Ireland. And then public outpatient polyclinics, health centres, community health centres, health clinics provide the other 20%. So the community health nurse, the public health nurse, and other community health facilities make up the other 20%. Again, quite similar to what we have in the Irish situation. When looking at stays in hospital, and hospital stays tend to be one of the most expensive parts of any healthcare system. As I said, the system is heavily subsidised, but the subsidy varies by the type of ward you want to stay in. So the accommodation here from A, B1, B2 to C is sort of the hotel accommodation in hospital. Are you looking for a 1-bed private room? Are you going to go for a 3 to 5 bed semi-private ward, a 6 to 10 bed ward, or an open ward? Clearly individuals would prefer to be towards Class A rather than Class C. If individuals were given the choice, all beds would be Class A. If you're providing the system, perhaps you want to have more people choosing Class C because it's cheaper to provide. Individuals get to choose where they stay. Do you want a Class A bed or a Class C bed? Just like going to a hotel, what type of room do you want? The individual must cover the cost of the accommodation though, and the subsidies are directed so that the charge differs greatly by the type of accommodation. If you want the Class A room, which make up 7% of total public hospital beds, there is no subsidy. So if you want the gold-plated accommodation, you pay all of it. If you're willing to choose Class C, the open ward, it's subsidised to the tune of 80%. Excuse me. Clearly this would be more expensive in the first place. So the cost for the patient is far higher, particularly with the subsidy of 0. This would be the cheapest in the first place and would be made substantially cheaper by the 80% subsidy. So the government again is subsidising and incentivising cost consciousness amongst the consumer. And here is the distribution of beds. So 7% are in the Class A, 16% Class B1, 28% Class B2 and 49% in Class C. And the type of accommodation does vary. If you're looking for a room with a view, large space, television, a couple of chairs, and whatever else you want, that would be your Class A. Class B has the televisions attached to the ceiling, plenty of space, large space between the beds, and relatively private accommodation given the curtains. Class B2, a bit more crowded. In fact, this and this look like to be the same room, except here you have 4 beds, and here you have 1, 2, 3, 4, 8 beds. So just much tighter accommodation in largely the same room. And the open ward, well, it seems to be a free-for-all. There's beds thrown everywhere. We give out about trolleys in Ireland, but there seems to be beds in every possible accommodation. So if you want to move from here to here to here to here, the subsidy increases. This the most expensive with the least subsidy, this the least expensive with the greatest subsidy. So again, encouraging cost consciousness. If you look at how much the average patient had to pay, or the median patient, for a stay in hospital. So this is patient bills for hospital stays across the different types of accommodation. The median bill for those staying in wards Class C was 580 Singapore dollars. That's less than €300. So again, the costs are heavily subsidised. As a full stay in hospital, you're getting the exact same medical care as somebody in Ward A. There is no difference in the medical care. What differs is the hotel accommodation. What are the costs you're incurring on the system? So the median, the middle bill, if you ranked all the bills from the smallest bill given to somebody who stayed in the Ward C to the largest bill, the middle bill, the 50th percentile, was €580. So 50% of people actually paid less than that. 50% of people paid more. The 70th percentile is 950 Singapore dollars, €475. So 70% of people paid less than that. And the 90th percentile is 2,270. So 10% of people did have to pay more than €1,000, perhaps for prolonged stays in hospital. But because of the nature of the subsidies, the nights built up. If you look at, so we look at the other extreme, Ward A with no subsidy, the average bill was almost 2,500 Singapore dollars. And these people can be getting the same healthcare. This isn't for the doctor or the procedure or anything. This is just the cost incurred. So the healthcare is the same, but the accommodation is different. So that's nearly 5 times the difference in the median bill. Same for the 70th percentile, about 4 times, and up to 4 times for the 90th percentile. When given the choice, 72% of patients in public hospitals stay in Class B2 or C, the first two, and 28% choose to go down here. And there's nobody giving out and saying, I want to stay in a private room. If you want to stay in a private room, you stay in a private room. It is your choice. It's not about knowing somebody in the system or nodding at a particular acquaintance you have in the system and getting them to help you out. It's down to choice. You go to the hospital, you sign up. It's your choice where you go. You don't ring a radio show and give out about what you are or not getting. So how does the system work? So we look at a worked example for a particular individual. So a patient has gallstones, some liver problem, and requires surgery to have them removed. So they've been to their GP, GP has said, look, you have this particular problem. I'll recommend a stay in hospital to get these removed. So what does the individual do from then? Well, the first thing to work out is how much do I have in my medical savings account? Where can I go to find out that? This next step is, well, how much can I take out? There are defined limits about how much can be removed and taken from the savings account for healthcare. Can't just spend it on a willy-nilly basis. Step 3, how much does the thing cost? And then step 4 is, what will I do? So how much do I have? How much can I get? How much does it cost? What's the decision? So this is the website of the Central Provident Fund. I could do it live. If you go to the Central Provident Fund, you get a website like this. But just to make sure it's working, I've taken the screenshots from the website, and we can work through it. So the Central Provident Fund is a bit like online banking. You have a particular account, you have a login and a password, you put in the password, you get to your account. So this could be the home page for AIB or Bank of Ireland. All sorts of news, services, what you can, what you can't do, what's happening, etc. What you're primarily interested in is just the button that says log in. How can I see what's happening in my account? So log in here, just like logging into online banking. So you'd put in your ID and put in your password. So whatever your ID number would be, whatever your password, and you get in then to your own online account from the Central Provident Fund. So it does require a fairly large investment in IT to set up a system like this. So this individual is Mr. X. Clearly I don't have a Central Provident Fund login account, but they do give samples. So Mr. X has 222,000 in his ordinary account savings for housing, education, insurance. He has 18,630 in the special account for retirement, and 33,000, which looks like the limit, in his medical savings account. So has built up substantial savings. Divide all those numbers by 2 to get them in euros. So he's looking at maybe 110, 120, 135,000 euros saved over a period of time. We know what age this person is, not quite sure, but he has substantial savings built up. So he's 33,000 in the medical savings account. So we want to look at and see is, well, what has been happening in terms of the transaction history. So you look at a transaction history across the various accounts. So you can see what he's doing with his money. He has in the ordinary account 222,000. He has about 81,000 of that in stocks. He's choosing to invest it. And 23,000 in gold. If this is 2008, he's in clover. So this individual gets to choose what they do with the money. And then they have the special account, which are not allowed to invest. That's put into directed accounts as set up by the Central Provident Fund. That is money the individual can't lose. They might earn a lower return on it, but it's money that they need for retirement. So you can see what the individual has been doing with their money. So education can take 16,000, and there's still 18,000 left for education. So we're looking at the medical savings account. 33,000 available. The individual has been making very small claims in their healthcare, 0. For a chronic disease as an outpatient, they have 300 Singapore dollars available immediately. To get an MRI or a CT scan, they have 600 Singapore dollars. They can make immediate claims, but there's 33,000 in the account. So if the individual has a gallstones problem and requires a hospital stay, they can pay for that from the funds from their medical savings account. So the next issue we need to find out is, well, how much would it cost? We have no problem having sufficient funds there. So the individual is looking to see how much it costs. So they have various calculators that are available. So providing for your healthcare needs, this 33,000 might be available, but how much can I take out? If I have healthcare needs, healthcare bills, how much can I cover from these tax-free savings I've built up? Do I have to meet it out of my own pocket? Do I have to go for my own income or my other savings? Can I just look at the medical savings account? So the MediSave, MediShield calculator helps you estimate how much you can claim from MediSave and work out how much is available. So what do we want to do? We want to work out how much of this 33,000 we can take out. So we're looking for MediSave, MediShield, or both. Well, it's just a gallstones operation. It's not catastrophic, it'll just be MediSave. And what do we want? Well, it'll require a stay in hospital, so it's hospitalisation. It's not a daycare procedure, an outpatient, or the delivery of a child. It's hospitalisation. So we click both of those and work out, well, where are we going to stay? So there's a community hospital, convalescent daycare, geriatric hospital, private hospital, or restructured hospital, which is basically a general hospital. So something like CUH. So where am I going to spend the money? In a private hospital? No, I'll use the public system and go to the general or restructured hospital. Which of these general or restructured hospitals am I going to choose? There was 8 of them. So we have the Alexandra, the Shangri General Hospital, the Women's and Children's Hospital, the National Cancer Centre, Heart Centre, University Hospital, Singapore General Hospital, the Tan Tock Seng Hospital, or Woodbridge Hospital. Don't know anything about them, but I know it's in Singapore. So we'll choose Singapore General Hospital. Working through. This is an actual example that I would have worked through. This is from the actual website. So Singapore General Hospital is the hospital we stay. So we're staying in a general hospital. We've worked out Singapore General Hospital. Next thing you say, well, which ward do you want to stay in? Do you want to stay in Class C, the open ward, or with 33,000 Singapore dollars saved, will we go for Class B2 or above? We'll go for the more private accommodation, the semi-private ward or the fully private ward. So we'll click Class B2 or above. That will again influence the amount you can claim and the amount you have to pay. Oops, how long will I be in hospital? We'll say 2 days. Day in hospital with the procedure, day recovery, out. Pretty minor procedure, shouldn't take too long. Will take 2 days. So what then is covered? What are we looking for? So we need to fill in what operation we're going for. So we can click the view to see which one we want. So here is we have gallstones, which is a liver problem. So you can go through all types of procedures you would go through in hospital. Hopefully your doctor will tell you what you're actually going to have. So with liver, removal of gallstones, colitis, something or to be, removal of gallbladder, laparoscopic, put up something or other, or a liver transplant. We'll go for just this one here, laparoscopic, something or other. So you'd select what you're going through. Removal of gallbladder, and it puts in the number. So now we have the type of hospital, the exact hospital, the ward, how long we'll be in hospital, and what they're going to do to us. And we just click next, and it says what you'll be charged. Well, you'll be charged €450 per day in the hospital. That's based on the type of accommodation you're going for. And you'll be charged €1,400 for the surgery. So €450, €700, €2,300, or just over €1,000 for 2 days in hospital. So that's the amount that can be taken out on the MediSave account. Sorry, that's not the amount that will be charged. That's the amount your MediSave account will allow you to take out. So you'll get €450 per day, sorry, $450 per day for every day in hospital, 900, and they'll cover 1,400 for the cost of the surgery. So of our 33,000, we can take out 2,300. So we can take a substantial amount out of the account to cover for this claim. The next thing we need to know is, well, how much will it cost? Is 2,300 enough? Will we have to dip into other resources in order to cover it? So the Ministry of Health, a bit like the HSE in Ireland, provides statistics on the health system. So there's a whole host of data out there. But one of the issues that's important is statistics. And one of the statistics is on the size of bills. Hospital bill size by condition, procedure. So we can see, well, clearly I'm not the first person to get gallstones, not the first person to require stay in hospital, not the first person to get this procedure. So how much was charged to other people? All this information is out there. The Irish healthcare system has no prices. You stay in hospital, you either don't face the price at all, the government pays where there's no prices, or some prices made up to charge the healthcare company. So looking at hospital bill size by patient. So this is averages across a whole range of people. And again, the same list of conditions are put up here. A to J, J to R, S to Z. So we're at gallbladder removal. Is what we're going for. And then the laparoscopic one. So it gives us the number of people who had the treatment in each of the hospitals. So N was at Nuffield, SGH, the Singapore General Hospital, and TTSH at Tan Tock Seng Hospital. So we see which hospitals are providing the treatment and for which ward. So this is Ward A, the highest quality accommodation. So the average stay in hospital varies from 2 to just over 1. So the Nutfield Hospital has them for 2 days. The Tantock just keeps them on average for 1 day. Some people stay 2. And here's the median bill, $4,900 up or down to $3,500. So the medical savings account was covering $2,300. If we wanted to stay in Ward A and get the treatment done in any of these hospitals, so we're going for the Singapore General Hospital, the median bill is $5,174. So the medical savings account covers less than half of that. If you want to go for Ward A in Singapore General Hospital, you must be prepared to stump up the extra amount based on the median. So the median is $5,174. You can reduce the quality and go for Ward B1. And again, you're getting the same procedure. What is changing is the costs you're incurring in the system. And you can see the median bill falling. So CGH, a different hospital, does it in Ward B1, $3,200. And Singapore General Hospital also has Ward B1s, and the price drops from $5,174 to $4,350. That's the median bill. If you lined up all the bill, what would be the 50th bill? So there was 86 people, whatever the time frame is, who stayed in Singapore General Hospital for this treatment. If you lined up from the cheapest bill that was issued to the most expensive bill, the one in the middle was $5,174. Half the people paid more, half the people paid less. If you went for Ward B1, 115 people chose it. If you line these bills up, smallest to largest, the middle bill would be $4,350. You can go through the different wards. So for Ward B2, 6 to 10 rooms in the Singapore General Hospital, you're down to 1,303 Singapore dollars. Or if you go for Ward C, the open ward, the median bill here is 892. 2 days in hospital, operation, accommodation for about €450. So the price varies substantially based on what the individual wants to do. And then you get to choose which one you're going for. So if you go for Ward C, you're allowed to take out 2,300. In fact, you'd only need, on the median, 892. So you wouldn't even need the full 2,300. You'd only be allowed to take out the size of the bill if the amount is lower. So for Ward B2, it would cover it. And for Ward B1, you'd have to put in perhaps a small amount yourself, maybe up to €500. But for Wards B2 and C, it'd be fully covered by the medical savings account. So the individual will then choose which one they're going to go for. Based on looking at Mr. X's profile, he seems to be a reasonably wealthy individual. He'd possibly choose one of the higher ones. Maybe Ward B1, semi-private accommodation, get the 2,300 from his medical savings account, and then pay perhaps an extra 1,000 Singapore dollars from his own resources. But he's staying in Ward B1 because he wants to. He's staying in Ward B1 because he weighs up the costs and benefits. He's not staying in Ward B1 because he's screaming and just feels he should get it because it's there. What's the additional cost to him? Why shouldn't he get a private room? So it is all about choice. And if people are of low resources, you can see the impact in the subsidies. People here are feeling the full cost of the hospital stay if they want the private room. But when we get down to Ward C, the costs are quite low. €892, the median bill for Ward C. So about €450. So it wouldn't take huge savings to hit that amount. So for Ward C, it is heavily subsidised. So it's not suggesting that there's no state expenditure. There is state expenditure, but it's targeted. It's trying to facilitate those who have the lower income. So does the system work? What do Singapore people themselves feel about the system? So the Singapore Ministry of Health commissioned a survey to determine public perceptions on healthcare in Singapore. So they got SingHealth Health Services Research to go off and do it. And it was done over a 2-week period, or just over a 2-week period, in 2006. So these are the questions that were asked, and they were asked based on the Likert scale. So the Likert scale is strongly agree, agree, neutral, disagree, strongly disagree. So it's a commonly used range for questions in surveys. So if you look at some of the opinions here and how they might differ in Ireland, I should be personally responsible for my own health. Over 90% of people have this view of personal responsibility. Only just under 6% were neutral or disagreed, and nobody strongly disagreed that the initial responsibility was with the individual. Over 3/4 of people saying that they have personal responsibility. Where should the money come from to pay for their healthcare? It is my personal responsibility to build my own savings to help pay for my healthcare expenses. Nearly over 70% of people, nearly 3/4, either strongly agree or the vast majority agree. 15% are neutral. Look, if I have to save for it, I will. Only 12% disagree. 12% say it's somebody else's responsibility. Somebody else should be paying. So clearly there are substantial differences in views on where the responsibility lies, whose money should be used. Interesting discussion last night on Vincent Brown about the amount of money in Ireland, whose money should be used to pay for particular services. We're magicking up 10 billion out of absolutely nothing. Asked whether it was their responsibility to buy medical insurance to help pay for high medical bills. Again, you're looking at fairly high levels of agreement, with perhaps only 15% disagreeing. There's a slightly larger view of neutrality, but again, more than half saying if I have high medical bills, I should have paid the insurance to allow me to cover those medical bills. Only 16% disagreeing. The government should fix the price of medicines in Singapore. So where do these prices come from? What role should the government have? Should the government be providing the money, or should it be providing the regulation? About 2/3 of people saying they should fix the prices, just as we saw in the previous example, with only 12% saying the prices should be free. So while there does seem to be a view of individual responsibility and market-based solutions, when it comes to the prices, they do argue and suggest a role for government. MediSave should be used mainly for the person whose account it is. If it's your savings, you can only spend it on you. Huge disagreement. 2/3 of people say no, that perhaps I have responsibility to those close to me, that I have responsibility to close relations, siblings, offspring, parents, etc. So 2/3 of people saying that there is personal responsibility, but there should be some risk pooling. So that if somebody I know is ill, I should be able to step in. In Ireland, if somebody you know is ill, you'll chain yourself to the gates of Leinster House. MediSave should be used at the discretion of the account holder. Again, large people tend to agree with that. So in our example, we saw that the person could only take out 2,300 for the gallbladder removal. There was limits on how much could be taken out and what it can be used for. So there is a view here that perhaps if they're saving the money and it's their money, they should be allowed to use it for what they wish to, or what they want. I'm familiar with the way the healthcare system in Singapore works. Well, there's maybe 1/4 of people who disagree with that. As we saw with the example, it is quite an involved process to go through the accounts to see how much money is there, to see how much is available, to see where this procedure can be provided, to see what wards are available, what the bills are, what the choice should be. It is quite an involved process. And about 1/4 of people are arguing that they're not familiar with the way it works. Healthcare in Singapore is generally affordable. It does have more agreeing than disagreeing, but about 30% are arguing that it's not affordable, even with the large subsidies put in place that make the cheaper accommodation substantially cheaper. Singapore has a good healthcare system. If you ask this question in Ireland, would you get 76 of people agreeing or strongly agreeing with that statement? And only 8% of people disagreeing. Does the healthcare system work? 8% of people say no. 92% of people are either neutral or agree with that phrase. So there does seem to be general acceptance with how the system works. So is it successful? Well, a high quality of healthcare services. Singapore also has an element of health tourism. People go to Singapore to get healthcare that might not be able to get elsewhere, and because of the regulated prices, they can perhaps get it cheaper. As we saw, increased life expectancy, low infant mortality. It does it at a very small resource cost, less than 4% of GDP. The reason that's important is the more money you spend on health, the less you can spend on everything else. They spend 4% on healthcare, so they have 96% on everything else. If the US is spending 16% of healthcare, they've only 84% left for everything else. So the more and more resources consumed by health, the less can be devoted to everything else. People are more aware of the need to be responsible for their own healthcare, and there is a very active community help and services for the needy. Again, this whole idea of where is the responsibility for healthcare services? Does the responsibility rest at the top? It's somebody else's job to provide me with my health, or does it come from the bottom? Are there problems with the system? Yes. All people without Medisave insurance not able to afford healthcare services because lots of their needs are ongoing. That they have regular healthcare needs. That it's not just a case of going in for one operation and leaving it at that. That they actually need regular treatments, regular medicines, regular healthcare services. And this pretty quickly eats up their health savings. So the Singapore system has been amended with the 3 E's. Elder Save, Elder Fund, Elder Shield. But they're still in their infancy, so it's not sure whether they're having the desired effect. It'll only be over the longer term that the impact of those will be seen. Healthcare costs are continuing to rise. Medical inflation is a problem throughout the world. And even with regulated prices, the Singapore system has seen them rise. And it's still very much dependent on government subsidies. Although whether that's a negative or not is hard to know. But there is still a role for government expenditure. So if you were to implement it, what is required? Well, the first thing is a willingness and ability to save. So people need to be able to understand savings and put money aside. In Singapore, it's compulsory. So you have to put the money in. You need high labour force participation in formal employment. Now, it's no use working in the black economy, paid in cash under the counter. That's not going to enter into medical savings account. And you need most people employed. So a country with structural unemployment like we're struggling through at the moment, with the impact on the construction sector and the fact that industries are collapsing and will need time for alternative employment to be found. It can also have an impact of population ageing. If you were to impose with an old population, they won't have time to save. You need an effective payroll collection with efficient fund management and claims processing. Could the Irish public sector handling working with something like the Central Provident Fund, dealing with claims from 3.5 million people? You need a well-developed information system with security and accounting controls. You need kind of an online banking approach that isn't subject to a tax or violations that can lead to losses. Public education for proper use of accounts. What actually is the funds available for? What can you use them for? In the investment side, what should you be investing in? The system clearly needs prices. How much does a stay in hospital cost? How much does an operation cost? How much does a procedure cost? Unless the prices are present, the system won't work. So in Singapore, they control the prices and create them. You need information on quality as well as prices. One thing we saw across the variable hospitals is how much the procedure cost. What is recommended to be added to the Singapore system is patient satisfaction. Not only the median bill, but do a quick survey of patient satisfaction. Is the cheapest the best? How do patients rate the treatment? So what is the quality as well as the price? So they have loads of price data, but very little quality data. So there is a suggestion that they should up it and add quality data to the system to allow the consumer to choose on the basis of quality as a lone price. So there are some similarities between Ireland and Singapore. Both are small, open economies that engage in substantial trade. In Ireland, you'd argue there's strong family ties and social support system. The whole concept of community hasn't been eliminated. We do have ageing and relatively affluent populations. We have a prior dominant tax-based financing system when we're still in the tax-based financing system. That's where Singapore came from. And predominant public healthcare provision, just as in Ireland here. What are the differences? Well, up to recently, we don't really have a strong propensity to save. We've gone through a huge boom where the savings rate was remarkably low. It's only in the bust that the savings rate has increased. But we're not saving to put money on deposit. Irish people are saving now to pay down debt. Savings is just income not spent. Most of the income now that people aren't spending is going to pay down debt. So the propensity to save in Ireland may not be there. We don't have the savings built up. Geography and population density. Singapore is a city-state. We do have cities, but a large degree of the population is in very rural areas. They have 13 hospitals covering the entire area. It's unlikely that 13 hospitals would be sufficient to cover the entire population of Ireland. And we all already have a socialised model of social security. Socialised model means everybody pays into a common pool, and it's from there that the withdrawals are made. It's not an individualised, which is a completely different approach. And the Singapore seem to have a greater willingness for individual responsibility rather than what we have here. So that is the Singapore health system. Told Dr. Shinnick, finished at 10 to.